So, hi everyone. Welcome to the Health for the World Grand Rounds. Today, our honorable speaker is Dr. Nosheen Yayavi Firozabadi. She's an assistant professor of radiology at Johns Hopkins University. Dr. Yayavi received her medical degree from Tehran University of Medical Sciences. She did her internship at the Cleveland Clinic Foundation, followed by diagnostic radiology residency at Mallinckrodt Institute of Radiology, Washington University in St. Louis. She then did a 2-year neuroradiology fellowship at the Johns Hopkins University, during a second year of which she served as a clinical instructor. Dr. Yayavi returned to Johns Hopkins in 2017 from Mid-Atlantic Permanente Medical Group of Kaiser, where she served as a subspecialty chief of neuroradiology. Her research interests include functional imaging, resting state fMRI, vessel wall imaging, and advanced imaging of stroke. She has authored and co-authored 25 peer-reviewed publications. We are honored to have Dr. Nosheen Yayavi give the grand rounds, and her topic today is non-invasive neurovascular imaging. Thank you so much, Nosheen.
Thank you so much, Bhavya, for introduction. It's a great honor for me to be here today with all of you. I'm very excited. I'm going to talk about non-invasive neurovascular imaging, mainly CTA and MRA, no conflicts of interest. So the conventional vascular imaging techniques that we use are commonly, besides ultrasound, which I'm not going to talk about today, are CTA, MRA, and catheter angiography. We're going to focus more on CTA and MRA today. I'm going to first talk about different techniques that we use in CTA and MRA, and then I'm going to show you some cases with some disease entities so that we can cover some of the more common disease entities that we in the brain. So for CTA, we normally use injection of contrast, about 45 to 120 ml. We inject it at a relatively high rate of 3 to 6 ml per second. We have to use different bolus monitoring techniques so that we can follow the bolus of the contrast and catch it in the arterial phase in the brain. Invention of newer multi-detector CT scanners has resulted in us being able to acquire very thin slices so that we can reconstruct them in different planes, do multiplanar reformats, and do this sorts of imaging, maximal intensity projection, like MIP. So this is an axial, this is a coronal MIP of CTA of the head, which can actually show us the areas of a stenosis or abnormality better. Also, we can do 3D volumetric rendering. So this can give us a better look at the overall picture of the vessels in the brain. Newer techniques such as dual energy CTA can help us with decreased beam hardening artifact, a strict artifact that we see commonly with CT, especially with dental amalgam or like an artifact from osseous structures in the level of skull base and posterior fossa. Also, it can help us eliminate the metallic stent or coil mass artifact that we see. So it can give us a better look at the vessels, even if there is metal around them. We can also do some dynamic imaging, what is called 4D CTA, which essentially you can acquire the data in arterial and venous phases. This is a 4D CTA, it's like arterial phase, and as contrast passes, you still acquire images and you can get a good look at the venous phase. So the 4D CTA data can be derived from CT perfusion data, which these days commonly is used for stroke imaging. So that's another good technique that we can use for evaluation of the vessels, both arteries and veins. Still, catheter angiography is still superior to CTA in temporal and spatial resolution. This is just a table to compare different MRA techniques. The common MRA techniques that we use are time of flight, contrast enhanced MRA, and time resolved contrast enhanced MRA. Also, there is phase contrast technique that I didn't put in this table. So we commonly use time of flight imaging for imaging of the vessels in the brain. It does not involve contrast injection. It's relatively a longer scan. It's about 3 to 5 minutes with the use of higher magnet strengths like 3T magnets, we can acquire very thin slices, and these are isotropic, so we can reformat them in coronal, sagittal. The way that we acquire images without an injection of contrast is that we use a time of flight effect. Essentially, you suppress the tissue, and then the inflowing blood is freshly magnetized, so we can capture the flow in the arterial phase. We use it commonly for the evaluation of intracranial vessels for the cervical villus, and also we use it commonly for evaluation of carotid bulb. As I said, the advantages with this technique are we don't use any contrast, and it's very good for intracranial vessels. However, it has a longer acquisition time, so if the patient is moving, it's sensitive to motion artifacts. Also, in the areas of that are slow or turbulent flow, we may have some loss of signal, which can be problematic. Contrast enhanced MRA is, technically similar idea, similar to CTA. You inject contrast and you try to image in the arterial phase. So it's a faster acquisition. It probably takes about 30 seconds for each phase, like arterial. We do also a venous phase. It has a slightly lower spatial resolution compared to time of flight. The physics behind it, you essentially image by T1 shortening by contrasting the lumen. It's really good for imaging of the carotid, and also for the intracranial vessels. If you have coil, stent, something that is causing a lot of artifact with time of flight, injection of contrast may help better evaluation for, like, let's say, recurrence of aneurysm after coil or stent. It's faster. It's great for evaluation of stenosis because time of flight can actually overestimate stenosis because of turbulence in the flow. And compared to CTA, it's not influenced by artifact from calcified plaque or artifact from calcification. So that's also an advantage over CTA. What are the disadvantages? Well, you have to have precise timing, similar to CTA. Make sure that you get the arterial bolus. You are not too early or too late. And it has relatively lower resolution compared to time of flight CTA and obviously DSA. Time resolved contrast enhanced MRA is essentially dynamic imaging using contrast enhanced. So you just continue imaging dynamic acquisition of T1 shortening in the lumen. It's good for evaluation of vascular lesions such as AVM, AVF, soft tissue vascular anomaly. It can give us a better look at what is the dynamic without, invasive imaging. And it has a lower spatial resolution and temporal resolution compared to DSA. So DSA still remains the gold standard for evaluation of soft tissue or, vascular anomalies, AVM, AVF. This is just a depiction of the difference between a 2D versus 3D time of flight MRA. So 3D time of flight MRA, which we commonly use for intracranial vessels, it's good for smaller region, which have various flow directions, like intracranial vessels. Let's say you have carotid, which has this, flow direction, and also like an MCA branches. So when you have multiple tortuous vessels, 3D time of flight is going to be the modality of choice. It has a higher spatial resolution. Obviously, it's going to take longer. So for a small amount of tissue, this is the modality of choice. And then again, as we said before, we have an isotropic voxel, so we can reformat it coronal sagittal, look at it at different planes. You can make MIPS or 3D volumetric images. 2D time of flight is good for long segment imaging, let's say neck vessels from the level of arch all the way to the skull base or in the extremities. It is more sensitive to slower flow as opposed to 3D time of flight, so it can catch slower flow. And it takes less of a time, however, it's sensitive to motion more than the time of flight. And it doesn't give us an isotropic images, so you have this stair-step artifact. So we commonly use the 2D if we don't want to give contrast to a patient for imaging of the neck vessels. This is an example of contrast-enhanced MRI of the brain. We normally acquire in the coronal plane, and it gives us a good depiction of all the vessels in the brain. I just wanted to show you an example of comparison between a contrast-enhanced MRI and time-of-flight MRI of the carotid ball. So there is an ulcer, and the carotid ball proximal internal carotid artery. You can see it here on both time-of-flight and contrast-enhanced MRI. But here on this exam, where the ulcer is more like proximally pointing, you essentially don't see it on time-of-flight MRI because there's turbulence of the flow within the ulcer, and our imaging doesn't catch that slow and turbulent flow. So contrast-enhanced MRI in the neck is superior to time-of-flight MRI, especially for detection of slow flow, turbulent flow, ulcerated plaque. As we said, time-of-flight MRI may overestimate the stenosis due to turbulence. Just briefly talk about time-resolved contrast-enhanced MRI. There are different techniques using different vendors, tricks or twist sequences, if you have heard about it. It gives us a dynamic look at the vascular anomaly. So this is a large venous lymphatic malformation of the left orbit. You can see it on this coronal tube and post FAT-SAT image. And this is a time-of-flight MRI. I'm sorry, it's a contrast-enhanced MRI using time-resolved technique. This is the arterial phase. You can see the carotid, the basilar. You don't see the vascular malformation. And as the contrast passes, you can start to see it in the venous phase. So it tells us that this is more of like a venous malformation. Our standard protocols where we use at Hopkins, if we do MRA neck with and without contrast, we do the 3D time of flight of only the ball, and then we do a contrast-enhanced MRI of the entire neck. If we don't want to give contrast for whatever reason, the patient, has an issue or end-stage renal disease or something, then we do a 2D time of flight of the entire neck vessels. As we said, it's good for evaluation of lung vessels. And then we do a 3D time of flight of the carotid ball. For the head, we routinely do a 3D time of flight MRI of the head. I just wanted to talk a little briefly about vessel wall imaging techniques. These are newer techniques that we use to evaluate the vessel wall. All the techniques we talked about, CTA, MRA, also catheter angiography, they evaluate the luminal narrowing. So what you're seeing is the lumen of the vessel. You don't see the vessel wall, and you don't know what's going on in the vessel wall. Is it thickened? Is there an ulcer? If it's not, what is the plaque burden? Also, if you want to evaluate for vessel wall to carotid plaque morphology, which helps us in deciding what patient needs to get treatment, vessel wall imaging technique can be helpful. It can be performed 2D or 3D acquisition. 2D along the short and long axis of the vessel, and then 3D techniques. These are different 3D techniques, different vendors now it's available that they do. And this is just an image of a cavernous carotid artery with an eccentric plaque. This is the lumen of the vessel, which is dark, which is the black blood. It is suppressed signal from the blood, and you can actually nicely see the vessel wall on this. I'm going to show you some examples of this as we go through the cases. Now I'm going to talk about common vascular diseases. We're going to talk about atherosclerosis, carotid, and also intracranial atherosclerotic disease, or ICAT. We're going to talk about arterial dissection. We're going to talk about intracranial vasculopathies. I'm going to talk about reversible cerebral vasoconstriction syndrome, or RCVS, vasculitis, and Moyamoya disease. And there's this large group of vascular anomalies, aneurysm, AVM, and AVF, which I think they deserve a separate talk. I'm not going to talk about them. We're going to try to talk about the first three categories. Let's start with carotid atherosclerosis. This is probably one of the most common things we see as neuroradiologists. It's a major cause of ischemic stroke. If the patient has symptomatic disease, meaning they had an infarct, and they have greater than 70% stenosis based on NASCET criteria, the patients are essentially being treated with carotid endarterectomy in addition to medical therapy because they have higher risk of recurrent strokes. If the patient is symptomatic with less of it, stenosis, kind of moderate, 50 to 69% of stenosis, the risk of recurrent infarction is lower. So the surgeons decide if they want to do endarterectomy based on other factors, patient demographics, and also what they want to know is plaque characteristics. So that's what our imaging is going to help. Is there ulceration? Is there intraplaque hemorrhage? Are there signs that will tell them this plaque may be unstable and cause more infarcts? This is just a depiction of how to measure carotid stenosis based on NASCET and also European criteria. So for NASCET criteria, we measure the narrowest diameter where the vessel is narrowed by this plaque, and also a normal distal caliber above the bulb. Remember, the bulb is normally, it's like dilated. If you measure it around here, you get it like an overestimation of degree of, you get an underestimation of degree of stenosis. So you have to measure a normal carotid bulb in a normal carotid caliber above the level of bulb. And this is the formula, A minus B divided by B. And this is the European criteria that they measure the estimated portion of carotid wall, which is, I think, harder to measure. So how can carotid atherosclerosis result in ischemic infarct? So there are two main mechanisms: artery-to-artery embolism, when you have a carotid plaque that, let's say, is ulcerated, you have a thrombus formation superimposed on it, and then you have a thromboembolic phenomena, meaning the thrombus goes up to the brain and causes an infarct. Or we can have hemodynamic stenosis, like the carotid stenosis, and there's poor flow, poor perfusion in the carotid territory. This is an example of carotid atherosclerosis resulting in ischemic infarct. This is the classic look of watershed or borderline infarcts in the right internal carotid artery distribution. And this patient had on ultrasound complete occlusion of the right internal carotid artery, and this is the CTA image that was reformatted. You see complete occlusion. How do we image carotid atherosclerosis? Carotid duplex is commonly performed as a first step, and normally after that, CTA or MRA are performed to document or verify the degree of stenosis. CTA is a fast modality compared to MRA. It's less sensitive to motion. It gives us a really great spatial resolution. However, it has some limitations. One of them is artifact from calcification. The dual source energy CTA can help with, subtracting calcium and giving us a better look at the carotid bulb and proximal internal carotid artery. This is an example of an ulcerated plaque. So this is the common carotid, proximal internal carotid. There is an ulcer, there's a little calcification, and this is the ulcer crater. You see contrast pulling into it. This is a good look of comparison of different modalities. This is a contrast enhanced MRA. This is a time of flight MRA. This is a CTA image. And these are black blood images before and after contrast, and also Doppler ultrasound. So you see, on time of flight MRA, you don't really see much of stenosis or an ulcer. However, contrast enhanced MRA nicely shows there is an ulcerated plaque, and the contrast fills the ulcer. On CTA, there is some limitation because of the presence of calcium, as we talked before, so that's one of the limitations of CTA. So here, in this example, contrast enhanced MRA gives us the best look at the this ulcer and gives us the correct measurement. This is a pre-contrast and post-contrast black blood imaging. So with carotid atherosclerosis, we get outward remodeling of the vessel wall, meaning you see a large amount of plaque burden that's out, that is like beyond the vessel wall when you look at it. So it doesn't really cause much of narrowing, but there's a big plaque, and as you can see, it's enhancing. In this example, Doppler ultrasound failed to show that there was a plaque that is actually ulcerated. So again, each modality has its own benefits and its limitations. It's important to know when we look at some images that there may be some limitations. This is a nice example of vessel wall imaging of a carotid plaque. This is a contrast-enhanced MRA image. You see there is high-grade stenosis of the proximal internal carotid artery with what looks like a big plaque. This is an axial contrast-enhanced image through the carotid plaque. This is the lumen that is suppressed. There's black blood. And this is a large plaque. It has different components. It has this enhancing portion that we call it fibrous cap. It's a sign of inflammation and it's a sign of vulnerability of the plaque. It has a large necrotic lipid core, which is normally low signal on T1 weighted image. There's this area of focal inflammation, focal enhancement that correlates with macrophage infiltration. And there are these little dark areas in the periphery that correlate with areas of calcium. So this patient went on to get a carotid endarterectomy, and this is the correlation from the histopathology. As you can see, there is this enhancing fibrous cap. There is this area of focal inflammation that they saw multiple foamy macrophages. And there are these areas of calcification in the periphery. So by looking at MR, or actually CT can also sometimes give us a good look. If you have obviously ulceration, that's a sign of vulnerability of a plaque. Enhancing fibrous cap is a sign of vulnerability of the plaque. If you see intraplaque hemorrhage, this is not shown in here, but if you see intraplaque hemorrhage, that's also a sign that this plaque might have been unstable or maybe unstable. Presence of lipid-rich necrotic core is also a sign of instability or vulnerable plaque. On CTA, if you have a plaque that is predominantly calcified and doesn't have much of non-calcified components, that's probably telling us that this plaque is more stable plaque, as opposed to when you see a large lipid core on CTA or see a lot of wall thickening and large burden of plaque with no calcium in it. Let's switch gears and talk about intracranial atherosclerotic disease. So intracranial atherosclerotic disease, or ICAD, it's causing about 8 to 10% of strokes in the US. It's more common in Asian, African American, and Latino population. It may coexist with extracranial atherosclerotic disease, but it has different set of risk factors. How do we get infarcts or strokes with intracranial atherosclerosis? You can have the plaque occluding the penetrating artery, like in basilar artery, it's commonly happening. You can have watershed ischemia or hemodynamic narrowing, or you can have, again, similar to carotid, you can have artery-to-artery embolism. This is an example of intracranial atherosclerotic disease. This is an MRA image angiography showing high-grade stenosis of the M1 and M2 segments, and this patient has an old right cortical infarct, right frontal infarct. Similar to carotid atherosclerosis, in early phases, when you have intracranial atherosclerotic disease, you have outward vessel wall remodeling. So you may see no or minimal narrowing of the vessel on MRA or CTA. This is an example of a patient with MRA image essentially showing no narrowing, but the black blood vessel showing a large eccentric plaque involving the basilar artery. These are the axial images through the basilar artery. Plaques commonly occur around the bifurcation and the proximal aspect of the vessels. So in MCA, it's mostly along the ventral and inferior aspect of the MCA M1 branch. In basilar, it's mostly against the, involving the ventral aspect of the vessel. Plaque components are pretty similar to carotid plaques, but it's kind of harder to see them because we're talking about much smaller vessels. This is an example of a cavernous carotid plaque. We have an enhancing fibrous cap. We have this T1 hypointense lipid core, and this little area dark signal is calcium, and that's the lumen of the vessel. These are examples of intracranial atherosclerosis on vessel wall imaging. That's an M1 branch There is a plaque inferior and ventrally involving the M1, resulting in narrowing. This is basilar, P1 segment of the posterior cerebral artery. There is area of narrowing, and as you can see, there's eccentric wall thickening with enhancement. This is a classic look of atherosclerotic plaque. Also, this is a right basilar stenosis, and you have eccentric wall thickening with enhancement. Also, it's nice to know that we can also image the vulnerability of the plaques with contrast enhancement of the ICAD. So a lot of plaques, I mean, a patient has multiple plaques, and then you want to see which plaque is causing the infarct. The ones that show higher degree of enhancement are more likely to be the cause of infarct. It's the patient with the left MCA infarct. This is a pre-contrast, and this is a post-contrast image showing enhancement in the vessel wall. Also, as I said earlier, remember that in earlier stages, we don't see luminal narrowing or CTA or MRA. This was a young patient with a cortical infarct, posterior right frontal lobe, and CTA, MRA, and DSA were essentially negative for any stenosis, and they were wondering, what is the cause of this patient infarct? Is it vasculitis? Is there something else going on? And then they did a vessel wall imaging, and there is a plaque in the carotid artery. It does not result in luminal narrowing, and it's enhancing. So that was diagnosed, the patient was diagnosed with intracranial atherosclerotic disease. Let's switch gears and talk about arterial dissection. Cervicocerebral arterial dissection constitutes about 2% of strokes. It happens most commonly in young and middle-aged population. The mechanism of arterial dissection, similar to aortic dissection, is when you have an intimal tear with blood tracking into vessel wall. And then you can have extension of dissection from extracranial arteries to the intracranial arteries, or you can actually have only isolated intracranial artery dissection. There are multiple predisposing factors to arterial dissection. What we see more commonly is trauma, like a patient with motor vehicle collision. Sometimes it's very mild or trivial trauma that can cause arterial dissection. There are a large group of arteriopathies that could cause arterial dissection, such as fibromuscular dysplasia, a lot of collagen vascular disease, such as cystic medial necrosis, Ehlers-Danlos, Marfan's. It's also seen more commonly in patients who have positive family history, recent infection, migraine headache. This is an illustration to show the arterial dissection of the carotid artery. Let's say the patient has a rotational injury. This is the carotid artery, and there is an intimal tear and blood is tracking to the vessel wall. So more commonly with the carotids, we see the arterial dissection right above the level of carotid bifurcation and extending to the level of skull base, petrous segment. So this is the more common location for arterial dissection of the carotid arteries. And this is for vertebral artery. Remember, the vertebral artery in the neck has different segments, V1, V2, V3, and then V4. So V1 is before it enters the foramen transverse area, and V2 is when it's within the foramen transverse area from C6 up to C2. V3 is a segment that is looping around C2 going to the skull base, and then a distal segment is V4, which also has an intradural segment. As you can guess, when there is a rotational injury, the more common segment of vertebral artery that can get involved is the V3 segment and also V4 segment, which we see dissections more commonly. It's just because the way that the anatomy is. This is an example of carotid dissection. Patient comes in with left basal ganglia infarcts. On CT and non-contrast CT, you can actually see the left carotid at the level of skull base is a little expanded with clot within it. On diffusion, sometimes you can actually see the thrombus. This was an MRA, contrast-enhanced MRA, shows abrupt occlusion of the proximal internal carotid artery right above the bifurcation. This is a time-of-flight image that shows intramural hematoma. Sometimes they call it a double lumen sign. It's helpful if you see it. You don't see it all the time. And this is a MIP image. This is an example of vertebral artery dissection. V3 segment, see there is, you can actually see there is narrowing and there's a dissection flap in the left vertebral artery. Vertebral artery dissection, sometimes all you see is like a little bit of wall thickening and narrowing of the lumen. This is an example of bilateral vertebral artery dissection. In one side, you can actually see the dissection flap. On the left side, however, it's just as like luminal narrowing. MRI can be helpful to detect dissection. Sometimes you can see the intramural hematoma. If you have a nice T1 fat SAT or a GRE image, you can detect a thrombus within the vessel wall. These are different angiographic look of the arterial dissection, and this is a fibromuscular dysplasia resulting in arterial dissection. What is the role of vessel wall imaging in arterial dissection? Sometimes it can help us to detect the arterial dissection when you have minimal luminal narrowing. This was a patient with narrowing of the distal V4 segment of the vertebral artery, which we actually see it commonly after pica, posterior cerebellar artery, takes off the right vertebral artery. Normally the lumen is narrowed. Dissection, sometimes you just see very smooth narrowing. It doesn't have always that classic, areas of irregularity or narrowing or dissection flaps. So the patient clinically suspected arterial dissection, and they did a vessel wall imaging. This is a non-contrast image. You see T1 hyperintensive intramural hematoma. This is a case of vessel wall imaging of a patient we had with chronic carotid dissection. This is like double lumen, false lumen and true lumen, and it shows enhancement after administration of intravenous contrast. So by suppressing blood, the vessel wall imaging can also help with detection of dissection. Let's switch gears and talk about RCVS. So RCVS is a reversible narrowing and dilatation of the cerebral arteries. The mean age is about 42 years. It's more common in women. There are associated triggers such as vasoconstrictive medications, illicit drugs, sexual intercourse, and recent pregnancy. The patient presents with classical sudden severe thunderclap headaches that can run and that can recur over a span of 1 to 4 weeks. What do we see on imaging? We commonly see multifocal areas of infarcts. We can see convexity subarachnoid hemorrhage or lobar hemorrhage and edema. This is a patient with multifocal areas of infarct. This is an MRA image of the same patient at the time of presentation showing multifocal areas of irregularity and bleeding. It involves multiple vessels, bilateral MCA, ACA. And the main thing to diagnose the RCVS would be its reversibility. So this is follow-up MRA after a couple of weeks that showed resolution of all those areas of narrowing. This is a black blood image through the narrowed vessel that didn't show any enhancement. So that's another finding that we see in vessel wall imaging as opposed to vasculitis or atherosclerotic plaque. Normally we don't really see enhancement, perivascular enhancement in RCVS. This is another classic case, 44-year-old woman with sudden onset thunderclap headaches while exercising. This is an MRA image showing multifocal areas of high-grade stenosis, kind of like beaded appearance of intracranial vessels. This is an angiogram. On MR, there were foci of convexity subarachnoid hemorrhage. You see there's lack of flare suppression in the left occipital lobe. Here, there is a little bit of, you can see on the GR image, there is a little bit of susceptibility, and patient had pretty heterogeneous perfusion because of all these areas of vascular narrowing. This is a different example. Patient presented with lobar hemorrhage, also areas of subcortical edema, and also areas of small amount of subarachnoid hemorrhage within the sulci. Like here is a left parietal, convexity subarachnoid hemorrhage. There's a little bit of subarachnoid hemorrhage in this left frontal sulcus, and the cerebral angiography showed areas of narrowing. This is another example. Angiography showing extensive foci of irregular beaded appearance of the intracranial vessels and extensive edema predominantly in the subcortical, white matter, and very heterogeneous perfusion. As I said earlier, with vessel wall imaging, we really don't see vascular vessel wall enhancement or perivascular enhancement in RCVS. This is a patient we had. It's a duplicated left posterior cerebral artery. That's the normal area of normal caliber of the vessel, and this is an area of narrowing. And as you can see, this is a normal caliber, and it's narrowed down to this here. We don't really see any enhancement surrounding it, and the follow-up MRI was normal. Let's switch gears and talk about vasculitis. Primary angiitis of the CNS, or PACNS, is an inflammatory arterial disease that is essentially restricted to the cerebral circulation. And it can afflict patients of any age, and it often responds poorly to steroids. They commonly present with a combination of encephalopathy, headache, seizure, ischemic or hemorrhagic strokes. On imaging, the findings we see on vasculitis are pretty nonspecific. We can see multiple areas of small infarct, multiple foci of hemorrhages. A larger group of patients we see with vasculitis are those who have secondary vasculitis. It can be secondary to large, medium, or small vessel vasculitides, such as giant cell arteritis, Takayasu, polyarthritis nodosa, Kawasaki, granulomatosis with polyangiitis. You can have vasculitis that are associated with systemic diseases or connective tissue disease again. These are probably more common than the primary angiitis. You can have it with SLE, rheumatoid arthritis, Sjogren's syndrome, scleroderma, or other causes for vasculitis, such as drug-induced cocaine, amphetamine, antiphospholipid antibody syndrome, lymphoma, intravascular lymphoma, graft versus host disease. And a large group of patients who have vasculitis secondary to viral, bacterial, fungal, or parasitic inflammation or infection. So you can have HIV, VZV, CMV, parvovirus B19, bacterial infections such as TB, fungal infections, Cryptococcus aspergillosis, mucormycosis. We see them quite often with immunocompromised patients, and parasitic vasculitis. These are some examples of vasculitis. This is a patient with Sjogren's syndrome. You can see there are areas of narrowing on angiography. The patient had multiple foci of infarcts bilaterally. This is a case of TB meningitis. Patient had right basal ganglion infarct, and on MRI, there's pretty classic leptomeningeal and abnormal enhancement predominantly in the basal cisterns and the skull base level. This is a case of VZV vasculitis. This is a young patient, came with bilateral basal ganglion infarcts, and MRI showed areas of vascular narrowing bilateral M1 segments. This was a case of VZV vasculitis. This is another example of cocaine-induced vasculitis. You can see perivascular inflammation and enhancement along this M2 segment of left middle cerebral artery. This is amyloid beta-related angiitis, a pretty classic look with multiple foci of susceptibility artifact from small macrohemorrhages. These are associated with pretty significant edema. You see T2 and flare abnormality in the subcortical and deep white matter. And on black blood imaging, we see a lot of perivascular inflammation and enhancement surrounding all these vessels. So this is an angiitis that is related to an amyloid beta. This is a case we had, 18-year-old woman presented with basically encephalopathy, some headache gait abnormalities, and she had a long history of progressive hearing loss. On MRI, we saw multiple foci of small infarct that were involving the corpus callosum, especially the middle fibers. This is a sagittal T2 weighted image. You see the abnormality of the corpus callosum. And on black blood vessel wall imaging, we saw extensive areas of leptomeningeal enhancement, areas of parenchymal enhancement. Also, she had enhancement of the cochlea and semicircular canals, which we haven't shown here. And she also had a retinal angiogram that showed perfusion deficit in the retina. So the constellation of findings were Susak syndrome. Vasculitis, so we can image it with vessel wall imaging that can kind of help us differentiate from other diseases sometimes. And what we see is essentially concentric luminal stenosis that involves multiple territories. And you can see concentric vessel enhancement. This is a case of small vessel vasculitis. That's the vessel which is enhancing. And there is concentric enhancement surrounding it that extends beyond the lumen of the vessel. It's just to show you how we can differentiate between vasculitis and intracranial atherosclerotic disease. So this is a patient with multiple foci of narrowing of the superior cerebellar artery, PCA, basilar. This is a pre-contrast and post-contrast image. There is concentric enhancement of the vessel wall. This is basilar, and also this is the PCA, P1 and P2 segments. So this was a case of vasculitis as opposed to atherosclerotic disease. As we talked earlier, you see eccentric vessel wall thickening and enhancement. We can also use vessel wall imaging to guide us biopsy of a suspected case of vasculitis. This was a case of 33-year-old man with primary angiitis of the CNS. So there was abnormal enhancement of the cortical vein and also an MCA branch, and this patient had targeted biopsy, which came back as PACNS. So that can help us also guide biopsy. The last thing I'm going to talk about today is Moyamoya disease. So Moyamoya disease is a chronic cerebrovascular occlusive disease, which has bilateral stenosis or occlusion at the terminal portions of the internal carotid artery. And patients develop an abnormal vascular network at the base of the brain. What we see in imaging, CTA, MRI, or DSA, is we see areas of luminal narrowing and occlusion of carotid termini, also proximal MC and ACAs, and we see a lot of collateral formation. The patients present with hemorrhagic strokes, ischemic strokes, and TIA. We also have a larger spectrum of what we call Moyamoya syndrome, which essentially anything that could cause occlusive vascular disease can cause Moyamoya syndrome, such as vessel wall abnormalities, atherosclerosis. You can have fibromuscular dysplasia, radiation-induced vasculopathy, collagen vascular diseases, connective tissue disorders, also infection. So a larger spectrum that we shouldn't probably mistake it with just Moyamoya disease. This is an example of Moyamoya disease, high-grade stenosis and essentially near occlusion of carotid termini bilaterally. Patient had multiple foci of parenchymal hemorrhage. This is an angiography image showing there is high-grade stenosis, which is pretty smooth, starting from above the level of bifurcation. And as you can see, the intracranial vessel, there's high-grade stenosis with near occlusion of carotid termini with multiple collateral formation. This is a classic angiography image, which they call it puff of smoke. All these like little collaterals that they develop at the level of skull base when there is occlusion of carotid termini. This is a patient with Moyamoya disease that presented with a left basal ganglia infarct. Okay, I think, and these are some references from what I talked about. I think we covered some of the more common vascular entities we see. I thank you very much for your attention.
Thank you so much, Nosheen. This was excellent. This was